Hi everyone, in this video I'll be discussing drug metabolism. Now, we are understanding pharmacokinetics with the help of a simple tablet, paracetamol. So when we started with paracetamol the journey, paracetamol was taken orally. It was absorbed from the intestine, it underwent first pass metabolism, then it was bioavailable, then it went to the heart, it got distributed from the blood vessel, and it produced action that is decrease in fever. Now, once the drug has produced action, the body will not keep the drug inside. Why? Because all the drugs what we are giving, they are chemicals and they are foreign to the body. So the body will not keep them inside. So it has to throw it. So the process of throwing the drug out of the body is what we mean by elimination. So we'll understand what is elimination, and in this video we'll understand what is the meaning of drug metabolism. So let us start the meaning of drug elimination. So the body will try to throw the drug out. Now elimination has two important processes. One is the drug metabolism. One is called the drug metabolism and one more is called the drug excretion part. Now there is a term for metabolism. The term is called as biotransformation. Now what do we do in metabolism? Now please understand why the drug stays inside the body, because it is lipid soluble. Now general pharma, if I make it water soluble, the drug is easy to throw it out, easy to get cleared out. So the purpose of metabolism is to make a drug which is lipid soluble into water soluble. Now what happens if it is water soluble? It is easily cleared out of the body. It is easily cleared out. So the purpose of metabolism is to convert lipid soluble drug into water soluble drug and easily thrown out of the body. That is metabolism. Now metabolism is also called by one more name. The other name for that is biotransformation. It is also called as biotransformation. Now why it is called biotransformation? You read the term transformation. What do you transform? You are converting lipid soluble into water soluble. And who is doing that? Biology. Our body system is doing that. That's why it is also called as biotransformation. Correct? Now, who will do this job in our body? Now, this job is mainly done by the metabolism is mainly done by liver. That is a major organ. Mainly. Apart from liver, there are certain enzymes present outside the liver. For example, they may be present in intestine. They may be present in placenta. In case of pregnant women, they are also undergoing metabolism, but major seat of metabolism is obviously liver. You have studied in biochemistry also. Now, if it is done in the liver, who will do this job in the liver? In the liver, we have liver cells, that is hepatocytes. In the hepatocytes, we have enzymes. Mainly, there are two types of enzymes we need to understand. What are those? One is called as the microsomal enzymes. And one more, they are called as non-microsomal enzymes. So we'll understand them later. Remember, there are two types of enzymes for metabolizing a drug. One is microsomal and one more is non-microsomal enzymes. Non-microsomal enzymes. Now there are two phases of metabolism. There is phase 1 and phase 2 metabolism. There are two phases of metabolism. One is called phase 1 and one is called phase 2 metabolism. We'll understand that later. So this is the meaning of biotransformation. It is also called as the drug metabolism. So the major site is liver. In the liver enzymes, we have two types of enzyme, microsomal and non-microsomal. There are two phases of metabolism, phase 1 and phase 2. Sir, is it always a rule that elimination should be having metabolism, then the drug will undergo excretion? Is it a rule? Not necessary for few drugs. Few drugs, they don't undergo metabolism. So the drugs will not undergo metabolism, they are eliminated as such. So what are the drugs which undergo direct excretion without metabolism? without metabolism. They don't undergo any metabolism, but they are directly excreted as such. The drug will come out like that. Examples for them, very, very important. The example is the favorite drug, cetirizine. Cetirizine will come out of the urine as cetirizine only. One more group of antibiotics, and they are called as amino. They are called as amino glycosides. So these are excreted as such without any metabolism. So that's the reason elimination means drug can come out without metabolism also, but in some rarer cases. Now there is one more special type of elimination. The drug undergoes one more special type of elimination. The name is called Hoffman's elimination. It is called as Hoffman's elimination. So it is called as Hoffman's elimination. Sir, what do you mean by that? Now it's a chemical reaction. So there what happens? There is spontaneous molecular rearrangement of the drug. Spontaneous molecular rearrangement of the drug. So this is just a spontaneous molecular rearrangement, and this doesn't depend on the liver or kidney or anything else. So this is a special type of metabolism, that is elimination process for two drugs. One is called atracurium and one more is called same cis atracurium. The name is called cis atracurium. So they undergo Hoffman's elimination. The specialty is they don't depend on the liver or kidney for elimination. So the question here is, are they safe in liver failure? Yes. Are they safe in renal failure? Yes. So this is a special type of elimination called Hoffman's elimination. Please mark it. Okay, so we understood the initial aspect, that is metabolism, and what are the other aspect, that is Hoffman's elimination, and certain drugs can get eliminated without metabolism also. Yeah. Okay, so let us start our journey. Let us understand the concept of biotransformation. So let us understand the concept of biotransformation. I told you transformation means you are converting a drug from lipid soluble into water soluble, and the major site is liver. Now this biotransformation has two phases. So let me write that it has two important phases. What are those? Phase 1. So these are called phase 1 reaction. Phase 1 reactions are also called as non-synthetic reaction. Phase 1 reactions are also called as non-synthetic reaction. Clear? Yeah. Coming to phase 2 reactions. Phase 2 reactions, they are also called as synthetic reactions. They are also called as synthetic reaction, or they are also called by another name, conjugation reactions. Conjugation. Now why it is called as conjugation? Because we add a group. Conjugate means add. You all know bilirubin. Yes. How do we throw bilirubin out of our body? You know from biochemistry there is something called glucuranoid conjugation. So when you add that group, bilirubin is easily thrown out. Same thing, if we conjugate a drug with some groups, they are easy to eliminate out. So let us understand what are the phases of this. Now phase 1, the synthetic, phase 1 is non-synthetic reaction. So we have oxidation. You know from biochemistry, oxidation means adding of oxygen. And remember, in phase 1, the most common reaction is oxidation. In oxidation, we have various types. For example, hydroxylation. Hydroxylation. So hydroxylation may be two types: aliphatic hydroxylation and aromatic. Aliphatic and aromatic hydroxylation. Then we have deamination and dealkylation. Dealkylation. Sir, should I remember all these things? Not required that much. Remember, oxidation is the most common phase 1 reaction. That much is fine. The second one is reduction. You know, reduction means adding of hydrogen or removing of oxygen is reduction. And then the third important one is hydrolysis. Now the name tells you hydrolysis means add water and lyse the compound. That's it. Hydrolysis. That's it. Then we have another process that is called cyclization. Now what do you mean by cyclization, sir? Suppose the drug is a straight chain. Cyclization will make the drug from this straight chain to ring structure. So it will make the drug into a ring structure, and that is the meaning of cyclization. Okay. Then the opposite of cyclization is decyclization. So what do you mean by that? It's simple. You already know this. Decyclization means if the drug is in ring structure, the metabolism will make it into straight chain. So that is the meaning of this. So remember, phase 1, basically we have 5 types: oxidation, reduction, hydrolysis, cyclization, decyclization. In that, the most common is oxidation. That much you remember. Okay, fine. Now moving on to the phase 2. Now phase 2 is also called as synthetic reaction or conjugation reaction. What are the reactions in this? So the mnemonic is 3G SAM. So what is that 3G SAM? What are the 3 Gs? The 3G I will explain to you. First G, what is that 3G? The first G is called glucuronide conjugation. So it is called as glucuronide conjugation. And I told you a classical example for that you learned already. It is bilirubin. And this is the most common phase 2 metabolic reaction. Phase 1 is oxidation. Phase 2 is glucuronide conjugation. Now, what are the examples for the drugs which undergo this? Examples you can remember the mnemonic biochem. There are plenty of drugs which undergo this, but I am just giving you some of the important drugs for your exams. Now, B stands for benzodiazepines. So, benzodiazepines, they undergo glucuronide conjugation. We'll discuss that when we come to sedative hypnotics. An anti-cancer drug, irinotecan. Then the oral contraceptive pills which are used to prevent pregnancy, that is conception. Then C stands for an antibiotic, chloramphenicol. Chloramphenicol. Now when we talk about chloramphenicol, we'll discuss it causes something called Graves' syndrome in the future. Now if you are giving chloramphenicol to a premature baby or a neonate, newborn, what is the problem? Chloramphenicol cannot be metabolized. Why? Because in a newborn or a premature baby, the liver is not developed. If the liver is not developed, enzymes are not developed. If the enzymes are not developed, what happens the problem? The drug is not metabolized. So the baby will develop something called Gray baby syndrome. We'll understand that later. Don't worry. Then we have atazanavir. Then atorvastatin. M for morphine, an opioid drug. Morphine. And metronidazole. And P for paracetamol. What we are discussing now, paracetamol, PCT. So the mnemonic is biochem. I'll repeat again: benzodiazepine, irinotecan, OCPs, then chloramphenicol, atazanavir, atorvastatin. Then we have the morphine, metronidazole, and PCT. So should I by heart the things now? Currently, just try to understand the concept first. Once you understand the concept, then you can memorize the examples. So currently, try to memorize the concepts. Okay, examples you will get it later. Don't worry now. Now we understood the first G, that is glucuronide. What is the second G, sir? The second G is called glycine conjugation. Sir, which drug will undergo that? One example I will give you. The name of the drug is aspirin. The name is called aspirin. One more G. So we have 3 Gs, right? So one more is called glutathione. So the glutathione conjugation is The classical example is, yes, the drug what we are discussing is paracetamol. So paracetamol undergoes that. So we know the 3G. Now what is the next one? SAM. S for the sulfate conjugation. Sir, who will undergo this sulfate conjugation? Again, the classical example is paracetamol. Sir, what are we understanding from this? Remember, a drug can undergo multiple conjugation reaction. The classical example is paracetamol. You can see paracetamol is undergoing glutathione, sulfate, glucuronide conjugation also. So, sulfate conjugation is paracetamol and a antihypertensive drug by the name methyl dopa. Then we have another one, A for the drug undergoing acetylation. Now, remember, these are all done by enzymes. So, what is enzyme? Enzymes are proteins. And where do you get proteins from? The genetics. So, there is something called genetic problems. We call it as pharmacogenetics. So, the acetylators may be two types. They may acetylate slow. So, we call them as slow acetylators. Or they may be fast acetylator depending on the enzyme. How much do they have in their body? If they are lesser enzyme, they are slow acetylators. If they have more enzyme, fast acetylators. We'll discuss that later. So it's a pharmacogenetic variation, and we have a separate video for that where we have discussed what is the meaning of pharmacogenetics. Now, what drugs undergo this? Example. So example is the SHIP drugs. So what do you mean by SHIP drugs? S stands for sulfonamides. They are called as sulfonamides. Yes, sir. H for hydralazine. Hydralazine. It's an antihypertensive drug. I for isoniazid. Isoniazid. And what is P for? P for an antiarrhythmic called procainamide. So along with sulfonamide, we can add one more sulfone, which is used in leprosy, dapsone. So they all undergo acetylation reaction. So we are done with 3G. 3G. Number one, most common is glucuronide, then glycine, glutathione, then sulfate and acetylation. So please remember the examples for mainly acetylation and glucuronide conjugation. Yeah. Then moving on to the last one. The last one is called M. What is M for? Methylation. So adding the methyl group is methylation. You know the classical example. To convert noradrenaline into adrenaline is a classical example of methylation. Yes. Now converting histamine into methylhistamine is again an example of methylation. Methylhistamine. Right. So these are the classical examples. Please remember these are the phase 1 and phase 2 reactions. Phase 1, oxidation, reduction, hydrolysis, cyclation, decyclation. Phase 2 is 3G SAM, glutathione, glucuronide, glycine, sulfate, acetylation, methylation. Which is most common in phase 1 is oxidation, or most common in phase 2 is glucuronide conjugation. Yes, we understood that. Okay, so once we understood the phases, let us understand what you mean by the enzymes, that is microsomal enzymes. So let us understand the specialties of enzymes. Now I told you there are two types of enzymes. One is called the microsomal enzymes and one more is the non-microsomal enzymes. So we have the microsomal and non-microsomal enzymes. Sir, what is the difference between the two? Let us understand that. The difference between the two is, where is the location of microsomal enzymes? The microsomal enzymes are present in the smooth endoplasmic reticulum. Smooth endoplasmic reticulum. And where is non-microsomal located? They are present in cytoplasm and mitochondria. Yes. So we are correlating with your biochemistry here. Yes. Integration. Now the main enzyme in microsomal enzyme is cytochrome. It is called cytochrome P450. The major enzyme is this. This is the major enzyme in microsomal enzymes. Then here in non-microsomal enzyme, the examples are esterases. So let me give an example of esterases. There are two important esterases. One is the plasma esterases. Plasma esterases. Now, usually the drugs metabolized by esterases are usually shorter acting. Please keep this in your mind. Usually the drugs metabolized by plasma esterases are very short acting. Classical example is a drug by the name esmolol. It's an antihypertensive drug, and an opioid called remifentanil. So these are very short acting. Now there is one more esterase called pseudocholine esterase. Pseudocholine esterase. Right. So this will metabolize two important drugs. One is the succinylcholine, and mevacurium. So we'll understand them again when we come to systemic pharmacology. Remember, usually the drugs metabolized by esterases are usually shorter acting. That is a point. So examples we understood: esterases, then amidases. So all these are classical examples of these things, that is the non-microsomal enzymes. Now another important point, the third point, is these microsomal enzymes, you can induce them. I will tell you what do you mean by that. These are inducible. Not only inducible, they are also inhibitable. You can inhibit these enzymes, you can also induce this enzyme. That means you can increase their number. What about them? Non-microsomal enzymes, they are non-inducible. That means you cannot increase their activity. But you can inhibit them. They are inhibitable. Okay, sir. We understood the differences. You gave the examples. Correct. Microsomal are in smooth endoplasmic reticulum. The major enzymes are cytochrome, and they are inducible and inhibitable. Now, which phases are undergoing in this? Now, please understand, in the microsomal enzymes, the phases are all phase 1 are done by this. All phase 1, and glucuronidation of phase 2. Only that is done by microsomal enzymes. So all phase 1, oxidation, reduction, hydrolysis, and only glucuronidation of phase 2 is done by these microsomal enzymes. Correct, sir? Okay. Now what about this? What about non-microsomal enzymes? They can do phase 1, all phase 1, as well as they can do phase 2. But what phase 2 they don't do? You can pause the video and answer this question. What phase 2 they don't do? Except, very good, in phase 2, except glucuronidation. All other phase 2 are done by non-microsomal enzymes. A classical example of phase 1 I will give you. So there are enzymes called MABO, monoamino oxidase, and an enzyme which will metabolize the alcohol, for example, alcohol dehydrogenase. So these are non-microsomal enzymes. Yes. So simply you remember, you have studied that in biochemistry. Microsomal enzymes are mainly cytochrome enzymes. They are inducible and inhibitable, and all phase 1 and only phase 2, that is only phase 2 reaction that undergoes microsomal enzyme reaction is glucuronide. Non-microsomal, they are present in mitochondria and cytoplasm. They can only be inhibitable, they are not inducible. Esterases, amidases, oxidases, dehydrogenases. So all phase 1 and all phase 2 except glucuronidation. The question is, will phase 2 be done by microsomal enzymes? No. What about phase 1? Yes, phase 1, both microsomal and non-microsomal can do that job. Glucuronidation is exclusively by microsomal enzymes. So depending on this only, the questions will come in your exams. Okay? Yeah. Okay, sir. We understood the point. Okay, so once we understood the difference between microsomal and non-microsomal enzyme, let us understand the specialty of cytochrome enzymes. So let me tell you about the cytochrome enzymes. So we call it as cytochrome P450. Now this cytochrome nomenclature, Suppose it is written like cytochrome 3A4. Now what do you mean by that 3? The 3 here will tell you the family of the enzyme. And what does A tell us? A tells us the subfamily. And 4 is going to tell us the isoenzyme of this, and you have studied that in biochemistry. So that is the nomenclature of cytochrome. And remember, these enzymes are going to metabolize majority of the drugs in our body. So there are subtypes of this. I have written one type, cytochrome 3A4. Now let me write the various types for you. Let me write here. So the first one what I am going to write is the enzyme cytochrome 1A 1 bar 2. So family, subfamily, isoenzyme 1 or 2. Now what drugs are metabolized by this? So AM is the first letter. So when you get up in the morning, you drink tea and coffee. So obviously the theophylline, theophylline and caffeine, these are metabolized by the cytochrome 1A 1 bar 2. And also, if you correlate with pathology, the pro-carcinogens, what is pro-carcinogens? If you activate them, they become carcinogens. They are also metabolized by cytochrome 1A 1 bar 2. Okay. Then cytochrome 3A 4 bar 5. Now this is the one most common drug metabolizing enzyme in cytochrome. Most common. More than 50% of drugs metabolized by these enzymes. More than 50%. So mark this. The name is cytochrome 3A 4 bar 5. That is the most common, more than 50%. Then the next one is cytochrome 2B6. It is called as 2B6. So it will metabolize an anti-HIV drug. The name is called nevirapine. Then efavirenz. These are the anti-HIV drug. And an anti-cancer drug by the name cyclophosphamide. I know these are factual, but you need to understand. But the main point you need to keep in your mind is the major metabolizing enzyme is cytochrome 3A4 bar 5. Next, the next important one is cytochrome 2C9. Now, what drugs are metabolized by this? Majorly, it is the drug called phenytoin and an anticoagulant called warfarin. So, phenytoin is an anti-epileptic drug. Warfarin is an anticoagulant drug. Similarly, we have another cytochrome 2C19, and the drugs metabolized by this is a PPI, omeprazole, and an antiplatelet drug, clopidogrel. Next, we have another important one, cytochrome 2D6. Now the drug D stands for dil or dimag. So the drugs which act on the dil, heart, antiarrhythmic drugs are metabolized by this. Antiarrhythmic. Then the beta blocker, for example, metoprolol. So these are the drugs used in dil, that is CVS. What about the drugs used in CNS? They are called TCS. TCS stands for tricyclic antidepressants. Then SSRIs, selective serotonin reuptake inhibitors. So these are mainly metabolized by these enzymes. Now the conversion of a opioid, codeine, into morphine, again this is with the help of cytochrome 2D6, very very important. And one anti-cancer drug, tamoxifen. So tamoxifen is an anti-cancer drug used for cancer therapy. This will become the active one, that is called endoxifen, and that is the active form. So that is also done by the enzyme cytochrome 2D6. Remember, more than 20% of the drugs are metabolized by this. So that's why the questions come from here. More than 20% of the drugs are metabolized by cytochrome 2d6. The last important one which I am going to tell you is a cytochrome called cytochrome 2e1. It is called cytochrome 2e1, and that is going to metabolize all the hepatotoxic ones. Usually the hepatotoxic one you can remember like that. E for paracetamol. You know that paracetamol toxicity can cause hepatotoxicity. Halothane can cause hepatitis. And then alcohol. Yes, you can know alcohol can also cause hepatotoxicity. So paracetamol, halothane, alcohol, they are metabolized by cytochrome 2e1. So if you observe this, you can see we have arranged them in the letter A, then B, C, D, and then E, right? So remember these 2 points importantly. The most common drug metabolizing enzyme is cytochrome 3A4/5. The second one is 2D6. Now always remember, since these are also enzymes, there is always a chance of pharmacogenetic variations. There is a chance of pharmacogenetic variation. So that is about the nomenclature and what are the enzymes and what are the major drugs which they metabolize, and we are given the list for that. So let us understand one more important aspect. I told you when I told microsomal enzymes can be inducible as well as inhibitable. What do you mean by that? So let us understand that term. Let me write the microsomal enzymes. Microsomal enzymes, they can be 2 things. They can be inducible, that is called induction, or they are inhibitable, that is called inhibition. So microsomal enzymes can be induced or inhibitable. Sir, what do you mean by induction? Now suppose I use a drug. A drug will induce the microsomal enzyme. What do you mean by that? Induction means the drug will increase the enzyme synthesis. The drug will increase the enzyme synthesis. Now you tell me, what happens if enzymes are more? Will the metabolism become slow or fast? Obviously, if more enzymes means more metabolism, so there will be increase in drug metabolism. Increase in drug metabolism. Now what happens if drug is metabolized more? Will the drug level fall or increase? Obviously, if it is metabolized faster, there is decrease in drug level. Now if the drug level falls, will the drug work correctly or will the drug fail to work? Yes, obviously when the drug levels decrease, there is drug failure. There is drug failure. Okay, sir. So inducer is a drug which increases the enzyme synthesis, and because of that the drug metabolism increases, drug levels decrease, and the drug will fail to work. The classical example which they keep on asking in the exam is, let me give an example of inducer. The inducer name is rifampicin. Now what happens if I use rifampicin? It's an enzyme inducer. Rifampicin is a drug used to treat tuberculosis. If I use rifampicin, let us understand an interaction now. If I use rifampicin plus oral contraceptive pills, OCPs, now what happens? Can you tell me? What happens to oral contraceptive pills? Now let me trace it again. When I use rifampicin is an enzyme inducer, so it will increase the enzyme. So what happens to the metabolism of OCPs? The OCP's metabolism increases. What happens to the OCP level? Decreases. And what happens to their activity? Fade. So rifampicin plus OCP will lead to contraceptive failure. Contraceptive failure. Okay, sir. Fine. Now what is the clinical based question for this? Question is simple. A patient was on oral contraceptive pill. Now why do we give that? To prevent pregnancy. Now she has been diagnosed with tuberculosis. She has to be given rifampicin. Now if she takes rifampicin, what happens? The contraceptives will not work. She will have failure. So what is your advice to her? Pause the video and tell me. So your advice to her is to stop that and use the barrier method of contraception like condom. So this is one of the clinical based importance of knowing enzyme inducers. So rifampicin and OCPs, they should not be combined. If you combine, there is contraceptive failure. Clear? Yes. Now the next important thing is, what do you mean by enzyme inhibition? Microsomal enzyme inhibition. Suppose I use a drug. If I use a drug, the drug will inhibit the enzyme. So it will inhibit the enzyme activity. The enzyme activity is inhibited. What happens if enzyme activity is inhibited? If the enzyme activity is inhibited, there is decrease in drug metabolism. There is decrease in drug metabolism. So what happens if drug is not metabolized? Will the level increase or decrease? Think and tell me. Yes, obviously, there is increase in drug level. So what happens if drug level increases? Obviously, it can lead to toxicity. So patient may develop toxicity with that. So toxicity can happen with that. Classical example I will give you. Now there is an anticoagulant called warfarin. There is an anticoagulant called warfarin. We use it to prevent and deep vein thrombosis. We use it to prevent clot formation. That is, deep vein thrombosis means there is a formation of clot. To prevent that, we use warfarin. Now, if for this patient, if I add a drug called ciprofloxacin. Ciprofloxacin is an enzyme inhibitor. Now, what happens to warfarin? Let us analyze. Let us come back to the chart. The drug is ciprofloxacin. So, if I add ciprofloxacin, it will inhibit the enzyme activity. Now, what happens to the warfarin? There is decrease in warfarin metabolism. Now, what happens to the warfarin level? Increases. Now, what happens to warfarin toxicity? Now, what is the toxicity of warfarin? If it is increasing, it's an anticoagulant. That means it will not allow the clot to form. So, if the clot is not forming, what is the adverse effect? Bleeding. So, patient will have the risk of bleeding. So, again, at drug interactions, I am telling you, warfarin and enzyme inhibitors should not be used. The complication is bleeding. So, please follow this flowchart. Very, very important, and plenty of questions come from this. Plenty of questions. Now, another question I just want to ask you. Tell me whether the induction is faster or inhibition is faster. Take a guess. Which process is faster? If you have a mobile in your hand, throw it down. To break the mobile takes time, or to make the mobile takes time? Obviously, to make it takes time. So, to make the enzyme synthesis means a protein synthesis, it takes time. So, induction is slower and inhibition is fast. You can do that immediately. You can throw the mobile, it will get broken out. It will be broken. So, please remember in enzyme induction and enzyme inducers. I'll ask you one more question, very, very important. Even if you don't know these drugs, just understand the concept. There is a drug by the name ezogabine. So it's a drug used to treat partial seizure. So there is an epilepsy condition called partial seizure. For that we use ezogabine. But ezogabine, with this ezogabine, the seizure was not controlled. So what the doctor did, he added phenytoin. He gave phenytoin to the patient. Phenytoin is an enzyme inducer. So, patient was already on a drug called ezogabine. Now, it was not controlled by ezogabine. So, doctor added one more drug, phenytoin, but it is an enzyme inducer. Now, the question is, when he is adding phenytoin, should he give the normal dose of ezogabine? Should he increase the dose of this or decrease the dose of this? Yes. Pause the video and try to answer this. Now, what happens if I give normal dose? If I give normal dose, it's an enzyme inducer. What happens? And the enzyme inducer will metabolize it faster. Now, what happens to drug level? There is decrease in drug level. Now, if the drug level decreases, the drug fails to work. So, what should I do? I cannot give the normal dose. So, what should I do is I have to increase the dose and give. If I increase the dose and give, the drug level will not decrease and the drug will still work. So, in this case, we have to increase the dose of ezogabine. So, these are the application part which keeps on appearing in your exams. So, all the three examples what I given, all have been asked in your exams. Very, very important. So, I told you what is slower and what is faster. Sir, okay sir, you told fine. Then what are enzyme inducer? What are the drugs? And what are enzyme inhibitors? What are the drugs? Let us understand that. So, examples of enzyme inducers, let me give them first. Enzyme inducers, the examples, the mnemonic is new, scrap, new scrap, new scrap. It is called GPS. New scrap, GPS. So what is that, sir? N stands for navy rapine. Now, navy rapine is an enzyme inducer. It is also called as auto inducer. Meaning of auto inducer means it will metabolize, it will increase its own metabolism. That's the meaning of auto inducer. S for smoking. Now, smoking is an enzyme inducer. Now, why smoking causes cancer? Because smoking stimulates an enzyme called cytochrome 1A, 1 bar 2. Now, what happens if you stimulate that? You know that it is pro-carcinogens. What do you mean by pro-carcinogens? They are the one which can cause cancer, but they are not active. They are made into active by this carcinogens. So smoking is an enzyme inducer. So it can stimulate this cytochrome 1A, 1 bar 2. So pro-carcinogens becomes carcinogens. Another anti-epileptic drug by the name carbamazepine. Now remember, this is also an auto-inducer. Auto-inducer. R for an anti-TB drug, rifampicin. A for alcohol. Now remember, in alcohol, is it acute alcohol or chronic alcohol? So we are discussing induction. So obviously it's a slow process. So it should be chronic alcoholism. Now that's a similar thing. I can give an example in the life. What happens initially when people start drinking, for a small big only they will get a kick. But later they have to drink more and more to get the kick because the enzymes get induced. So more enzymes means alcohol is also metabolized. So they don't get a kick. So chronic alcoholism is going to cause enzyme induction. So very, very important. And P for another anti-epileptic, that is called phenobarbital. Phenobarbital. And G for an anti-fungal drug, griseofulvin. And P for an anti-epileptic drug, phenytoin. I just told you the example. And M for a herbal plant that is called St. John's wort. So St. John's wort in the Western countries, it is used as antidepressant drug. It is used as antidepressant. So it's a herbal preparation. So the mnemonic is new scrap GPS, nevirapine, smoking, carbamazepine, rifampicin, alcohol. Remember, chronic alcoholism, phenobarbital, griseofulvin, phenytoin, and herbal drug St. John's wort. These are inducer and it's a slower process. So once we know the inducers, let us understand the inhibitors. So microsomal, what I am telling you is microsomal enzyme inhibitors. So what are the examples for that? So the mnemonic, before I come to the mnemonic, first let me write the drugs only. I stands for isoniazid. It's an anti-TB drug. I am. So what does AM stand for? AM stands for azole group of antifungals like ketoconazole. Then alcohol. It is acute alcohol. Remember, acute alcohol is inhibitor. Acute alcohol means it's a immediate process only, right? So inhibition is faster. So that is the reason acute alcoholism. And an antiarrhythmic drug, amiodarone. So I am. What are I doing? I am eating. So what does eating for? E for an antimicrobial. The drug is called erythromycin. I am eating what? Very. What is that V for? A drug called verapamil. A drug called verapamil, that is a calcium channel blocker, and valproate, an anti-epileptic drug. Remember, most of the anti-epileptic drugs are inducers. Valproate is enzyme inhibitor. Again, this is frequently asked question in exam. Now, I am eating very what? What very? Very good. So what is that good for? Good for grapefruit juice. Now please remember, don't confuse with grape juice. Grape juice is the normal juice what you drink. Grapefruit is different. You can Google it and see. Grapefruit looks like orange. That is the grapefruit juice. So it's an enzyme inhibitor. Then fresh. The drug name is called fluoxetine. Fluoxetine. So I am eating very good fresh. What is the fresh one? Chocolate. So in chocolate we have 3 C's. Cimetidine. Then ciprofloxacin, I gave the example. Ciprofloxacin and clarithromycin. Then I am eating very good fresh chocolate. P's. P stands for protease inhibitors. So protease inhibitors used in HIV, they end with navir. Example I will give you. The name is called ritonavir. Then the last one is only, and the O stands for a drug, omeprazole. Right, so the mnemonic is big, it's okay, but you have to stick that in your room, write it down, and you have to see that every day. And also when we come to systemic pharmacology, I will teach you all these things. So these are the examples for enzyme inhibitors. I am eating very good fresh chocolate piece only. Isoniazid, azoles, acute alcohol, amiodarone, erythromycin, verapamil, valproate, grapefruit juice, fluoxetine. The 3 C's are cimetidine, ciprofloxacin, clarithromycin, protease inhibitor, and omeprazole. So in general pharmacology, don't worry about examples currently. Try to understand the concept. So what is the concept I need to understand? Let me summarize. I am discussing drug metabolism. Drug metabolism, there is something called biotransformation, making the drug lipid soluble into water soluble. The major site is liver. We have enzymes, microsomal, non-microsomal. We have 2 phases, phase 1 and phase 2. You can induce the enzymes, inhibit the enzyme, that is microsomal. There are certain inducers and inhibitors. We discuss the examples here. So inducer will increase the enzyme and they increase the drug metabolism and they decrease the drug level. Inhibitors, they inhibit the enzyme, so they decrease the drug metabolism and increase the drug level, leading to toxicity. So this is the point you have to keep in your mind. So once we discussed the examples of inhibitors, inducers, and all those things, the standard drug what we are discussing is paracetamol. Now what happens to paracetamol actually when we give it? That is a drug which we have taken the example to understand pharmacokinetics. Let me tell you what happens here. The name is paracetamol. Now when the paracetamol is used, paracetamol has to be metabolized. So it undergoes metabolism, and that is the glucuronide conjugation and the sulfate conjugation. So mainly it is glucuronide, so it will be made inactive by this. Now can you tell me which phase is glucuronide? It is a phase 2 reaction, and 98% of the metabolism of paracetamol is with this glucuronide and sulfate conjugation. So 98% is with that. So this is the phase 2 reaction. Okay, fine. Now another 1 to 2%, the paracetamol is metabolized by the enzyme called cytochrome 2E1. I have given the example of this. This will lead to a production of a toxic metabolite that is called NAPQI. Sir, what do you mean by NAPQI? NAPQI stands for N-acetyl para benzo quininoimine. So it is a toxic one. Now NAPQI is toxic to the liver. Why it is toxic to the liver? Wherever it finds the proteins of the hepatocytes, there it will go and binds and damages it. But when we take paracetamol, nothing happens, because whenever the NAPQI is generated, we have in our body glutathione. So glutathione will block that toxicity. So glutathione will block that toxicity, and glutathione will convert this NAPQI into mercaptouric acid. Mercaptouric acid. And that will go in the urine. So when we take paracetamol, nothing happens. So we don't get liver toxicity because we have very good glutathione, and that will go. So remember, 98% is undergoing phase 2 reaction, and 1 to 2% will follow this pathway, that is cytochrome and then glutathione. So please remember one more important point. Phase 1 is the cytochrome enzyme, phase 2 is glutathione, right? You may ask a question, sir, is there any rule that phase 1 then phase 2? Does all the drug follow that? No. The drug can directly go to phase 2. Example I have given here, paracetamol can directly go to phase 2. Or they can go to phase 1 then become phase 2. Or they may not undergo metabolism, they can go out also. I have given the example of cetirizine. Okay sir, fine. So when I take 500 mg of paracetamol, nothing will happen. My body will not get hepatotoxicity because we have the enzymes to metabolize paracetamol, no problem. But when is the problem? The problem is when you take paracetamol with higher dose. Suppose a patient has taken 10 tablets of paracetamol. Now what happens now? He has taken higher dose. When he's taken 10 tabs of paracetamol, what happens? Paracetamol has to be thrown out. Now this pathway gets saturated. Why? Because you are given a lot of drugs, the enzymes get saturated. So where does paracetamol metabolism now divert? The paracetamol metabolism will now divert to the 1 to 2%, that is cytochrome 2E1. So you will generate more and more NAPQI. When you generate more and more NAPQI, the glutathione will try to metabolize into mercaptouric acid and try to stop the toxicity, but this will also get over, this will also get saturated. Now when that gets saturated, the production of NAPQI is more in the body, and this will lead to hepatotoxicity. So patient with paracetamol overdose will have hepatotoxicity. They will have that. Now what to do? The glutathione stores are also depleted. The enzyme is converting this into NAPQI. What to do? That's the reason the antidote for paracetamol toxicity is a drug by the name N-acetylcysteine. The name is N-acetylcysteine. Now what does it do? It will give back glutathione. So it will replenish the glutathione stores in the body. So when replenish, glutathione will come to the action and it will neutralize the toxic metabolite, and damage to the liver is prevented. And that's why the antidote for paracetamol toxicity is N-acetylcysteine. We know the concept here. See how beautiful the concepts are. Yes. So this is the understanding of paracetamol metabolism. Normally what happens, but what happens when we give higher dose of the drugs? The drug will accumulate and it will lead to toxicity. So once we understood the metabolism of paracetamol, let me ask you a question. What is the fate in a chronic alcoholic? Suppose a chronic alcoholic takes higher dose of paracetamol, will the damage be more or less? You will be telling yes only, because chronic alcoholics already the liver is damaged. But one more problem with chronic alcoholics are, I told you chronic alcoholics, they have enzyme inducers. They are enzyme inducers. So they can increase the activity of cytochrome 2E1. So if a chronic alcoholic takes higher dose of paracetamol, the toxicity is more in him compared to the normal individual, because paracetamol is converted to NAPQI and the toxic metabolite is generated faster in him compared to normal people. So that is the importance of understanding the induction again here. So chronic alcoholics are going to suffer more compared to normal individual if there is paracetamol toxicity. Yeah. So we understood the metabolism of paracetamol, and the drug what we discussed is paracetamol itself. So now we are throwing out paracetamol and we understand how it is metabolized. Let me conclude, there is nothing like phase 1 then phase 2. It is simply the drug has to be thrown out either directly by phase 2 or by phase 1 then phase 2 then throw out, right? So once we understand this, let us understand what is the fate of metabolism. So when the drug is metabolized, what happens? Fate of metabolism. fate of metabolism. Now, what happens actually when we metabolize a drug? Obviously, if a drug is active, after metabolism, it will become inactive. The drug will become inactive. That's the most common fate. That's the purpose of metabolism. Second important aspect is a active drug after metabolism can give rise to an active metabolite. So what do you mean by that? Let me take an example for this. The drug is active. The metabolite formed is also active. What is the example for that? The example is diazepam. If you metabolize diazepam, it will give rise to non-diazepam. Non-diazepam is also active. Then we have a first generation antihistamine called hydroxyzine. If you metabolize it, you get cetirizine. That is also active. We have antidepressant. Example is amitriptyline. After metabolism, it gives rise to nortriptyline. So these are examples of active drug giving rise to active metabolite. So the drug is also active, the metabolite is also active. That is the simplest. The third important aspect is an active drug. The third important aspect is inactive drug after metabolism will give rise to active drug. Sir, why should I give a drug inactive and make it active? Now, this concept of inactive drug is also called as prodrug. So, you can ask a question, sir, why like this? Now, there is a disease called Parkinson's disease. What is the problem in Parkinson's disease? The level of dopamine is less. When the dopamine levels are less, what should I do? I have to give dopamine. But when I give dopamine, dopamine doesn't cross the blood-brain barrier. If I give dopamine, it will not enter the brain. So I cannot give dopamine. So what should I do? I should give a prodrug. For example, I should give levodopa. So levodopa will become dopamine. But how will that help, sir? Suppose this is the barrier. This is called the blood-brain barrier. And this is the brain. So when we give dopamine to the patient, dopamine will not be able to enter. It will not cross. So I cannot give dopamine. So what I do is I will give levodopa. Now levodopa can enter the blood-brain barrier. Levodopa enters the blood-brain barrier and inside it becomes dopamine. So to deliver the drug like this, we have to give prodrugs. One advantage we have. Yes, example is levodopa becoming dopamine. Second importance of prodrug, I will give an example. There is an antibiotic called clindamycin. Clindamycin is very bad taste. So if I give like that, patient will not be complied. That means he will not take the drug regularly because of bad taste. So what we did is we added something called phosphate to that. So the name is called clindamycin phosphate. So clindamycin phosphate was made, and after metabolism it gives rise to clindamycin to avoid the bad taste. One more example for this is a urinary antiseptic called methenamine. Methenamine is called as urinary antiseptic. Urinary antiseptics are the antiseptic which act locally and kill the bacteria in the urinary tract. Now, when it enters the urine, there is a pH of urine which is acidic, it becomes formaldehyde. So, formaldehyde is the one which kills the bacteria, which kills the microbes. Now, you may ask a question, sir, can we give formaldehyde only? No. Can we drink formalin? Formaldehyde? No. It is highly irritant to the stomach and it's toxic. So, I cannot give it. So, I have to give methenamine to avoid the toxicity. So, it will go to the urine and becomes formaldehyde and kills the microbes. So, these are the advantages of giving prodrugs. These are the advantages. So, meaning is the drug should be inactive After metabolism, it should become active. Then only it is called as prodrug. Sir, what about diazepam? Diazepam becoming not diazepam is not an example of prodrug because already the drug is active. Metabolite is also active. It's not an example. Okay. Yeah. Sir, what is the disadvantage? What is the disadvantage of prodrug? Disadvantage. So you have to answer this question. Emergency. So can I give drug in emergency? Prodrugs. Already patient is dying. If I give prodrug, it has to go inside, get metabolized, and become active. So emergency, these are not useful. Second, these are not useful in liver disease. Suppose a patient has liver disease, they are not metabolized faster and they will not become active faster. So in liver disease and emergency, these prodrugs are not useful. Very, very important point. Right. So I was telling you the fate of metabolism. What are the fate? Active drug to inactive drug, that's the most common. Active drug to active metabolite, and inactive drug to active drug, that is called prodrug. Next, the fourth one is an active drug after metabolism will give rise to toxic metabolite. And you know the example for this. Yes, can you guess the example for this? You know it. Yes, just now we discussed active drug is paracetamol. Metabolism can give rise to the toxic metabolite NAPQI. Recently this question came in the exam. Which drug will give rise to NAPQI? Paracetamol. Now one more drug, isoniazid, a TB drug, and after metabolism it will give rise to toxic metabolite, that is acetyl hydrazine. So this is an example of active drug can also give rise to toxic metabolite. So these are the fates of metabolism which we need to understand. These are the fates of metabolism. So in this video we discussed the drug metabolism, right? What do you mean by metabolism? To convert a lipid soluble drug into water soluble. It is also called as biotransformation. Now in biotransformation, who is going to do that? Liver. That's the major site. Who in the liver? Enzymes. There are two enzymes, microsomal and non-microsomal. How many phases? Phase 1 and phase 2. Phase 1 we have 5 reaction, oxidation, reduction, hydrolysis, cyclization, decyclization. Phase 2 we have 3G SAM. The 3Gs are glucuronide, most common, then glutathione, then glycine, sulfate, acetylation and methylation. Phase 1 what is most common? Oxidation. Phase 2 glucuronide conjugation. So some examples you have to remember. Then the microsomal and non-microsomal. Microsomal enzymes, mainly it is cytochrome enzyme. Phase 1 and glucuronide are by phase 1. Phase 1 and glucuronide are mainly by microsomal enzymes. Now non-microsomal, they can only be inhibitable and they are going to cause the reaction, that is phase 1, phase 2 except glucuronide. Now once you know this, there is an enzyme called cytochrome enzyme. The most common drug metabolizing enzyme in that is cytochrome 3A4/5. More than 50% drugs are metabolized. Now then we understood microsomal enzyme, there is induction and inhibition. And induction means there is increase in enzyme synthesis. If there is more enzyme, more metabolism, there is decrease in drug level and drug failure. Rifampicin, OCPs. Enzyme inhibition, the enzymes are inhibited, so metabolism of drug decreases, the drug level increases, leading to toxicity. Example is ciprofloxacin and warfarin. Then we gave the examples of inducers and inhibitors. Then we understood the fate of paracetamol metabolism and the fate of metabolism of all the drug. So common fate is active drug giving rise to inactive one. Then active drug giving rise to active metabolite. Inactive drug giving rise to active drug, that is called prodrug. Active drug giving rise to toxic metabolite. Example is paracetamol giving rise to NAPQI. So that is about drug metabolism, and in detail we have discussed that. Thank you all.